Okay, I think we'll begin in the interest of time. So welcome today, everyone, to the AVITH in Context webinar. I'm Carolyn Davies, a Senior Project Officer at the Centre for Excellence in Child and Family Welfare. I'll just begin by acknowledging country and recognise that we are all joining today from Aboriginal land. We pay our respects to Aboriginal and Torres Strait Islander people and acknowledge elders past, present and emerging, and extend this respect to any First Nations colleagues here with us today. We acknowledge that sovereignty was never ceded and that this always was and always will be Aboriginal land. The AVITH in Context webinar series has been developed by the Centre, Victoria's peak body for child and family services, and is supported by Family Safety Victoria. Through this webinar series, we hear from a range of professionals in various fields, exploring the different contexts and different presenting issues that might impact a young person using violence and their family. Today's webinar addresses a challenging area of practice when fetal alcohol spectrum disorder, or FASD, is a contributing factor in the young person's use of violence. Our guest speaker today is Professor Anita Gibbs of the University of Otago in New Zealand, who has been researching this topic for some time. She also has lived experience as the adoptive mother of two young men, one with confirmed diagnoses of FASD and both living with additional neurodivergent disabilities. Professor Gibbs brings a strengths-based social model approach to this discussion about disability, believing that it's when people, systems and structures fail or refuse to accommodate difference that a person's experience becomes truly disabling. She also advocates for a disability rights framework, which challenges every system to ensure that those who are particularly vulnerable are given the means to participate fairly and equitably alongside their peers without disability. So for today's webinar, the usual webinar housekeeping applies. We'll pop a reminder of that in the chat. Please do add any questions to the Q&A box and we'll hopefully get a little bit of time to answer some of those at the end of the session today. So thank you very much, Professor Anita Gibbs. I'll get you to unmute and it's over to you. Thank you.
Well, kia ora koutou, everyone. Ko Dartmoor te Maunga, ko X te Awa, ko Anglo-Saxon toku iwi, ko Devonian toku hapu, ko Exeter Cathedral toku marae, no Ingarangi aho, and Gari ke Otapoti toku kainga, ko Anita Gibbs toku ingoa, tēnā koutou. I have just said greetings to you in Te Rio, and to say that I'm originally from England, but I've lived in Otapoti, Dunedin for the last 25, 26 years. And at some point in our lives, we had a birth child and we adopted two lads from Russia. More of some of those things later. And thank you for that wonderful introduction. Basically what we're going to do today, and we'll hope that my slides work. We're doing a couple of glitches before, but let's hope for the best. Click. What we're going to look at is FASD, but obviously it's intersections with, we call it different names, don't we? But child and adolescent to parents violence and abuse, CAPFA for short. I mean, we know there are a range of ways of saying what we're talking about today, so just excuse my particular version. And, you know, also, of course, I'm drawing on my lived experience and my social work hat. I still remain a registered social worker, very committed to the profession, as well as sometimes being very alarmed at what the profession does. So we'll look at the links, FASD, and perhaps comment on neurodisabilities as well, broadly, to CAPFA. We'll draw on some research that I've undertaken, and I'll give you a link to an article recently published. And just, yeah, I'll give you lots of resources for tips and tricks, so to speak. sorry, I'm just wanting to go to some definitions. Okay, now FASD, FASD, it's pronounced differently in different countries to some extent, but essentially FASD, and I mean many of you may have some prior knowledge, stands for Fetal Alcohol Spectrum Disorder. A lot of people still say syndrome, but we do know it as a spectrum disorder, like we would say autism spectrum disorder, although people often would just use the word autism as well. And we haven't actually come up entirely with a less stigmatizing term yet, because FASD at the moment is somewhat stigmatizing. But essentially it's lifelong disability that children are born with. They didn't choose to be born with this disability, but obviously it's as a consequence of prenatal alcohol exposure, and it affects their brain and body. There are a lot of new research coming out around the physical impacts on the body, various sort of ailments and issues and challenges that they're often happening to young people with FASD younger than you'd expect. So there are lifelong physical impacts. Each person, of course, has both strengths and challenges. We'll talk, obviously, because of the way we're thinking about this topic, a little bit more perhaps about the challenges, but each and every child has their strengths. And of course, the trick to giving people good lives is to obviously find out those strengths and try to nourish and nurture what they have got to offer to help them succeed. So they'll need often special supports. Not at all times, but often, because the diagnosis is a significant diagnosis. When people are diagnosed, they'll need helps throughout their life, but at different times and places. I've used the term at times. It's a brain-based disability affecting all parts of the body. It affects the physical, emotional, cognitive, mental, spiritual. It's about well-being. You can't disconnect the whole body. People try to. Often I find people talk to me and go, well, we'll fund the bit of your son that's accepted to be funded, but we don't want to hear particularly about the FASD. We'll fund the autistic bit of your son for services and helps, but we don't want to hear about the FASD. And that's coming from disability providers sometimes. And I'm going like, he's a whole person. He's a whole person. And he's going like, I'm a whole person. I'm a whole person. Same with mental health. You are too complex. We can't fit you into our little boxes. So it's lifelong. It's it's not a behavioural issue that can be cured. People so often are obsessed with it being a behavioural issue that can be cured or treated. Yes, there'll be things that can happen, and we can talk about some of those strategies, but positive behavioural supports and so on. But you can't reason FASD out of a person. That's why it's really important to understand it's a brain-based a challenged disability condition. It's like you're not trying to reason autism out of people. So it's the same with FASD. Yeah, we have to be very careful, how we approach understanding FASD. So yeah, I'll unpack that a bit more. So in terms of, well, again, you may have heard this, identifying, assessing, diagnosing. It's a big area. We don't have enough going on in any of our countries in terms of being able to send our children and young people to get assessed and diagnosed. About where what we call case ascertainment studies have been done, where thorough testing has been done to identify FASD, we have found that about 80% of those diagnosed with FASD were previously misdiagnosed with other things like ADHD, autism, conduct, behavior issues, all manner of things. So where there's not a lot of expertise on FASD, the misdiagnosis and missed diagnosis happens regularly. So you often find people get something else first, and somewhere down the track, they may get to an FASD clinic or somebody who knows more about FASD, and they go like, hang on, let's just see if we can find out a bit more about your background and actually ask the question around FASD. So At the moment, it's thought, in terms of supported and funded disabilities, that it's recognised as one of the leading known causes of developmental disability, and its prevalence, as far as randomised control types of case ascertainment studies are concerned, around 4%. But obviously, special populations, those in care, those engaged with justice, vulnerable groups, adopted, fostered groups, and so forth, the prevalence rates are going to be much, much higher. Probably not too surprising to most of you listening. Also, of course, there's the neurobehavior disorder associated with prenatal alcohol exposure, also known as the ND-PAE. That's can be used or has been used by mental health because it's coming out of the DSM. I'm not sure how widely used it is, because I think it was 2015 it got into the DSM, maybe, or 2014, but it was right at the end of the book. It's acknowledged as an alternative definition for FASD. In some cases, mental health professionals would give people this diagnosis, ND-PAE, and that's acknowledging particularly behavioural and mental health, impacts that have been, if you like, the etiology is because of prenatal alcohol exposure. So when we're thinking about what's going on for our young people and children, the sort of primary issues, there is quite a lot of overlap, obviously, with things like ADHD and autism at times, but you've got things going on in executive functioning, fundamentally memory issues because of brain impairment in reality across domains. We talk about the 10 brain domains in FASD. But executive functioning is a biggie, of course. Impulse control, problem solving, emotional regulation, planning and sequencing, a big thing. And this, of course, is noticed quite early on, but not labelled, I suppose. But it could be labelled. I remember my preschoolers being labelled things like, oh, they're just high velocity kids. That was quite polite way of saying, oh, pretty much they're off the wall. But hey, they're just high velocity. Preschool was sympathetic, less so once we hit primary school, out of control, insensitive, pushing the boundaries, rude. I mean, just every possible negative term, one imaginable. And that was prior to, I guess, us identifying specifically FASD. So social functioning is a biggie. That's where you obviously get overlap sometimes with autism in terms of communication. A lot of these children are very sociable, great expressive language, but often, they don't actually understand what you're telling them back. They say they will do, and they appear to be engaged, but actually, when you fully try to unpack, did they understand any instruction you just gave them? No, not really. The adaptive functioning is also a biggie. How can they survive in everyday life? And often it's this idea of dysmaturity that's really important in relation to FASD, that children behave younger than their chronological age. And I think this is where people get fundamentally impatient with young people living with FASD and young adults, because they expect them to have learnt by now to be acting their age, to surely have worked out how to adapt to new situations to be able to function well in society. And the reality is, no, it's not that simple. It could well be that this lifelong disability, which hasn't yet been diagnosed, is actually a lifelong disability. In terms of FASD, some of you, again, might be familiar with these 10 brain domains, and getting an assessment diagnosis is difficult unless you've got, health, multidisciplinary health teams already set up in your hospitals, obviously next to impossible in rural areas. Canada have been doing some great telehealth diagnosis pilots and schemes. Possibly in remote parts of Australia, that's also happening, but it's actually quite a long process to fully, get a sense of what's going on for children and youth, because it's very thorough. So although it has crossovers, as I say, with some of the other neurodivergent conditions, the recommended international guidelines tends to look at what we call these 10 brain domains, so all of those ones around the circle of this person's brain. You know, there are some physical measurements, but the sentinel facial features people talk about, often caregivers will come away from a pediatric appointment saying, well, they said my son doesn't have FASD because he doesn't look FASD, or GPs. And actually, maybe only in 10 to 15% of cases will there be 1, 2, or 3 sentinel facial features. So a thin upper lip, a smooth vermilion, I think it's called, or eyes look width, parapupil, fissures are sort of certain measurements. Okay, there are 3 sentinel facial features. You can, you know, do your own research on that. But really, 90%, a lot of children with FASD may not show what we call the classic facial features. So that's why it's a spectrum. That's why it's really important to understand that there are people who are substantially affected who look normal, which is obviously the way we do, sadly, make our assumptions about people in society. So to get a diagnosis, though, is very hard. It can be very costly. In New Zealand, it's about $9,000 if you're paying for a private assessment, New Zealand dollars. You know, sometimes the public clinics you know, you can get referrals. A lot of the time it's through the courts. Sometimes the child welfare services will pay, so a little bit of money for people undertaking permanency. But it's really difficult for families to get funded, etc. And of course, luckily in Australia there are some services, but you know, again, there are queue of people. So how easy is it for people to get the services that they need? And I think in terms of thinking about a profile, this lovely slide given was shared by Colleen Burns back in a presentation. She's from the Canadian groups of FASD clinic experts. You know, what you see is not what you get. So you will have apparently a capable, often somebody not with an intellectual disability. I mean, again, for the FASD profile, maybe only 20 to 30% of those might have an intellectual disability with an IQ score under 70. So again, the vast majority will be deemed to be of normal IQ, but they have this glitchy profile. And this glitchy profile, particularly in the adaptive functioning area, you know, will say, yeah, they can chat to the heart's content, talk about things apparently, and they can write sometimes well, or they can read well. But actually, maybe some deeper comprehension is challenged. Maybe no idea about times, they fail their appointments, you know, because they haven't had enough reminders. Their social skills are left wanting, you know, in terms of just organizing how they make friends, keep friends, who they choose for their friends. Oh my gosh, I've certainly experienced that in our own family life, where I've been on the same level of significance and importance of some of the most ropiest folks around, and I thought, well, how can I be less important than that ropey person that you just went and lived with for 3 days? But apparently so at the time. The spontaneity and impulsivity is off the roof for both my lads, but one of mine in particular. So there's lots going on in this glitchy profile, and it's useful to, I always find it's a good way of me reminding myself when I get frustrated with my own circumstances. We talk about primary impairments or primary issues, then of course the secondary challenges are massive, which is why we see large numbers of children with either diagnosed or suspected FASD in our youth justice populations, as well as our child welfare systems. So much international research from North America, but also plenty from Australia now that you know, look at sort of high rates of school exclusion, involvement with child welfare, getting into trouble, unfortunately higher rates of attempted suicide and suicidal ideation, massive co-occurring mental health issues, you know, just double whammies, triple whammies, whatever you want to call them. And even if, I mean, like in our own case, you know, where the person, you know, is adopted early, they have a fantastically loving, stable, solid upbringing, good opportunities. You know, if they really are impacted, these things still absolutely happen. So sometimes you can't stem the tide. You're just trying to harm minimize, shall we say. I'm not going to dwell too much on this particular slide, but to say that there have been researchers that have tried to do, and I was listening to a talk by Raja Mukherjee from the UK, who's a UK champion of FASD psychiatrist. He's very knowledgeable about that crossovers between autism and ADHD and FASD and other conditions. People have tried to sort of you know, we talk about a cluster of symptoms, I guess, to say that, well, how will I know if it's FASD or ADHD? I mean, I'm not a kind of neurobehavioral expert in that sense, in terms of using some of those psych assessments. But there are a couple of things I could say. I mean, there's some great screening research by Corin and colleagues that have looked at things like, you know, the kind of screening, you know, ticker thing. So is your child, you know, being mean? Do they lie? Do they cheat? Do they, you know, whatever, what's going on here? Do they have poor attention? You know, are they restless, hyperactive, impulsive? And you know, basically they try to, you know, or have been able to obviously do some testing to suggest that obviously perhaps where you've got a cluster of the symptoms in blue here on my screen, plus the green ones, they might have FASD associated, or ADHD associated with FASD. In other words, you know, FASD could be the big thing. You do need to know, obviously, and confirm that there've been some prenatal alcohol exposure. But where children perhaps are just, you know, just have concentration issues, impulsivity, more your classic. This, of course, again, begs questions about what do we do with girls. It's probably based, I mean, looking at boys perhaps, and perhaps some of these children also respond to medications better, the traditional ADHD medications. Perhaps it's more likely to just be standalone ADHD. But I'm not, I mean, looking at the overlapping behavioural characteristics in that chart there that I've given a reference for, there's lots of crosses in the FASD. You know, there's people with FASD appear to have all difficulties, and then all the others might have less difficulties. I think there's a lot more work to be done on that, because we are not diagnosing people adequately or sufficiently at this stage. So I still think it's really necessary. You know, my son, youngest son, has triple you know, he has a lot of diagnosis, but it includes FASD, it includes autism, it includes ADHD, and it's possible we could have got the autism one much earlier than we actually did, but there still would have always been that prenatal alcohol exposure in the background of my son. So autism is the one that got him some funding for disability services. FASD didn't. So I was like, yeah, we'll take autism. That's what you get, like, as a parent. We'll take autism. That's going to get us some help. And there were no experts to kind of be able to say otherwise, shall we say. Okay, let's get on to the crossover, because I know what will happen is I will run out of time. And I mean, of course, this is where you yourselves as practitioners and others have a lot of knowledge already, okay? But let's just say we know there are lots of definitions. You know, there's some brilliant ones all around the world in terms of what is this child and adolescent to parent violence and abuse. CAPVA for short, my use. I mean, Baker and Bonnet, great work in the UK. You know, they talk about harmful behaviour, controlling behaviour, abusive, you know, it can be physical, verbal, emotional, all of those things, physical, financial, property-based, sexual, you know. It can be intentionally harmful and controlling, or unintentionally harmful, okay? I mean, certainly when you've got a child with a disability, you're willing to look at these definitions and go, well, unintentionally. I like that word. I don't like the word intentionally, even if it appears that way, because I know my lad's brains. Cotterell, one of the earliest definitions, that any act of a child that is intended to cause physical, psychological, or financial damage to gain power and control. Gaining power and control, yes. But understanding these kids, I might have a 20-year-old who's operating at a 10-year-old level, and sometimes even younger, particularly with these autistic meltdowns, like 3-year-old toddler, gaining power and control. Yeah, but in a toddler way, even though the impacts can be big, of course, not to diminish those. So I like Patterson's Australian author definition: behaviours considered to be violent if others in the family feel threatened, intimidated, or controlled by it, that they need to adjust their own behaviour. And I think that's the reality for lots of FASD families, if you like. We're all about adjusting our own behaviour to accommodate, and at times that can be absolutely horrendous, because that's about surviving violence. And this is where it gets really tricky, because we often feel we're incredibly alone. Now, again, causes of CATVA, you'll have been unpacking this many, many times in your daily work and through previous seminars. I won't say too much, but communication difficulties, anxiety drivers, impairments from cognitive disabilities and challenges, yes, sensory processing, auditory processing issues, not being accommodated by systems, absolutely. So often our kids come home from school like that Coke bottle, shaken up all day, not been accommodated, very stressed, feeling bullied and harassed, not understood. Square peg, round hole. Safe place at home, doesn't take much, all hell breaks loose, and suddenly we've got a lot of violence and chaos happening. It just happens in a moment. You can't even see those triggers. You can't sometimes know that it is about to explode, even when you know your child so well. For others, it's having, not having stable, loving family presence, backgrounds. Yes, some others might be living with violence and trauma on a daily basis. Yes, others might see violence in the home. That might be an influence. Of course, we know also about parenting styles. People have talked about permissive or authoritarian. But, the reality is neurodivergent conditions are misunderstood, and particularly FASD is misunderstood. And of course, we don't talk about it because it's kind of like taboo. Yeah. I'll talk more about how CATVA is experienced, but I mean, I've experienced, pretty much all manner of CATVA, where I've, had whatever, so much damage, car windows broken, threats, this, that, and the other, knives coming in my direction, and I've had to involve the police, and it's just it can be relentless and overwhelming, and on a daily basis at times for some people. Again, prevalence rates are varied, underestimated often, depends on a whole load of things, of course. Some groups might be more vulnerable, single parents, families, perhaps adopted and fostered populations. Judy Selwyn and colleagues have done some great work in the UK that explored what was happening with disruptions in particular. But for some people, the sole reason their families disrupted and children ended up back in out of home care was purely because of the unaddressed abuse and violence that that they were facing in parenting their children. We've got obviously plenty of research going on in Australia, Fitzgibbons and colleagues and others that you'll know, that when they've looked at adolescence and violence towards caregivers and parents and so on, I've talked about at least 18% having neurodivergent conditions. But that's probably the tip of the iceberg. I mean, I suspect it's more. I mean, my own little study with 56 caregivers, about half of them, just over half of them, talked about this issue. We'll go on to hear from them. And then PEGS UK is pretty good at sort of doing surveys of their callers, and half of their callers. In relation to its links to FASD, well, we've got impulsivity issues that can, that lack of regulation, emotional regulation from an early age. I mean, for a lot of these kids, particularly with FASD, it's from a very early age. And it's all of those primary impairments that I mentioned earlier. It can be things like what we call perseveration, cognitive rigidity, where I mean, we've had meltdowns for Mars for a long time, but it'd be little things like something serious would happen where you'd think that child should be upset. I don't know, somebody shoved them, another toddler shoved them. You think, well, they might be upset, but they don't get upset about that. I mean, they don't cry at the thing you expect them to cry at. And then they're just the tip of the lid of their pen just pops off or something, and then you have a 3-hour meltdown, and you're going like, do not compute. There's the reaction does not equate to the apparent problem, but that clearly was, we had loads of examples, and you'd go like, surely a 3-hour tantrum, that is not worth it. But anyway, you couldn't reason at that point with very young children. I would say I've only been able to start reasoning a little bit with my 19-year-old. I might have been able to start reasoning with him maybe at age 16 or 17. Not much before that, I'll be honest. So it's kind of interesting, again, because of that. What's the sort of brain age, or what's the profile of the challenges to be able to know how to connect? I'll show you a video soon about what I try to do when my son is dysregulating. So there's these, connections between demands and requests, even asking a child a small task. Perhaps I've asked in an overcomplicated way. That can lead to massive meltdowns. Poor adaptive skills. And it's about that recognition that they may be operating at a much, much younger age than their chronological age. So our expectations are way too high. So in the FASD community, we always talk about lowering your expectations, not in a demeaning, deficit, negative, judgmental way, but in a kind of like, hey, what is the capacity of this child? What is seriously their capacity? Even if they're doing okay at school, is their relationship and communication capacity 5 years off their academic performance? And I think that's the important thing about the glitchy profile. They can function academically sometimes really well, but at another level of survival and of communication and of relationship engagement, it is completely off their chronological age. So there are definitely links for sure. And, as I say, plenty of my community, going on to my research, talk about this issue. And I interviewed 56 caregivers, about 20 of whom were birth relatives. The rest were obviously long-term foster carers, adoptive parents, permanent caregivers, and so forth. And a large group identified as Indigenous people of New Zealand, or having Indigenous children to care for. That link down the bottom is you can access the article for free. So I'm just going to share some quotes. One quote was talking about living in the fire, not just fighting fires, but living in the fire, because for them it was a daily experience. Albeit that a lot of my caregivers understood that kids were reacting. So it's reactive aggression, I guess, to the triggers and demands. But you had to find out what those were. And for many years, I experienced some abuse and violence, from my other child. But, there's a lot of it was because he was really unhappy at school, but he didn't give the impression that he was. So we kind of made a lot of assumptions that weren't quite right for him. And we sort of discovered this much later down the track. And so those kind of pressures are not there anymore. We've seen quite a lot of dip off from the aggression and so forth. I mean, the reality is, it's still violence. It's still experienced as violence, depending on what it is. So we still have to, find ways to help our people. So the role of being a parent is overwhelming. Yes, for some people, it's broken things. Everything, the cost goes up. They have to give up their jobs. people do get assaulted. It is all the things that people perhaps might try and tell you if you're caregiving for a family where there is an issue of violence and abuse. Caregivers, and parents get utterly exhausted, and they often blame themselves too. And you're on the edge, always on the edge. And it's exhausting living with it year after year. And in another talk, I talk about living year after year with this issue in my own life, probably 10 years or so. So that's a lot, isn't it? You have to become incredibly resilient and find resources to survive, but often there are no specialist ones in relation to FASD, so you have to kind of create your own. It can be a downward spiral. Some people, get really very low and almost suicidal themselves. I mean, it's actually really important that we find out about the impact on caregivers. So often the focus ends up on the child or the adolescent. And yet, actually, the caregivers love their kids, parents love their kids, and they really want them to have a good life. So where is the connection? I didn't find a lot of help or support for us, I'll be honest, and many of my caregivers also tell me that, systems failed them, because they got judged, they felt judged. Even if people didn't say outright, "Oh, your parenting's a bit dodgy, isn't it?" It was just sort of messages that they felt professionals weren't always understanding them or taking them seriously, particularly if professionals didn't turn up to see what was going on in the home. In other words, come see us at the office. So it's a sort of a systemic issue, really. Criminal justice involvement was generally always a disaster. It just criminalized the child and didn't actually necessarily solve any of the issues. And parents just wanted first of all, understanding, but then of course bespoke services that actually understood FASD first, and then understood the violence and abuse in the context of FASD. People obviously talked about some help from professionals that was positive and could input. So in terms of strategies, probably not rocket science stuff, but people would talk about all the different things. A, appreciating the qualities of their children. B, implementing, and I've got resources, so you can have the PowerPoints available to you, where I've got lots of recommendations in terms of the FASD stuff. But using systemic, structured approaches to simplify things for their kids. Using humour. I love this one about, I never used to swear so much. I told a psych nurse that, I'm having problems here, and I said, I think I've got FASD-induced Tourette's, and she said, what do you mean? And I said, well, since we've had such and such, I've sworn more than ever. A little humour is incredible, although sometimes the humour seems a little bit dark. I wish my son actually drove the car off the cliff today, and you go like, did I just say that to my social worker? Don't say that to your social worker. But it's a stress relief, and you've got to be honest, because the stress is insurmountable, and most social workers, professionals, and others who have to endure the stress that families living with FASD, and they layer on violence and abuse, they wouldn't. It would be, being a social worker, I don't think they'd cope that well. You have to have remarkable resilience and support systems, because you don't have that many people to turn to. Think of all the years where women couldn't talk about being beaten up by their partners, because they had nowhere to go, and the shame was deep. Well, what do you think, parents, particularly professional parents, competent parents, well-qualified parents, those that potentially have avenues to get help, when they feel that they're struggling and just unable to get supports? Goodness me, we're not talking about it enough to get the help and specialist services, and certainly not in Aotearoa, New Zealand. I'll be straight up with you. Self-care, 100% vital, of course, and there are many ways. Obviously people talk about going on walks. I do a lot of aqua jogging, music, art, whatever, but people feel imprisoned in their own home sometimes, particularly when the children are younger. And so it's like, what in-house supports can be provided? And so few are provided. And it's, do you have family members and relatives who can, do stuff? It's all about the informal But some people don't. They become isolated. This issue can be really, really isolating for people. And so, yes, self-care is vital, and parents want, those helping to learn about FASD. There are online support groups, of course, now for FASD in particular. So there's a lot of peer-to-peer support that we try and enable in New Zealand. But again, the violence issue is kind of like, oh, we don't talk too much about that because we might put parents off adopting or fostering. That's difficult as well. Professionals feel that, I think, and so I think it's hard and tough working in the field. Anyway, I'm going to play a quick video of my own way of coping with some of this stuff. Let's hope it works. Hello again. Here we are in the gardens getting some R&R respite. Just want to share a few things that I do in order to try and get through and survive crazy rages, crazy behaviour, crazy abuse, etc. I mean, obviously prevention would be good, but it's not that easy, is it? It depends on the whole situation that you have in front of you or that's unfolding. So if one could distract your lovely, beloved sons and daughters, that would be fine. But usually, in my case, dealing with a distressed teen who's on the phone, very distressed, dysregulated, or if he's been drinking or he's got upset by others, then there's a massive blow up. So prevention is not easy. Then there's damage or verbal abuse, and in the past that could last hours, but less than maybe 30 minutes these days. So that's okay, except that it can be still extremely distressing and sometimes catastrophic, even in a short amount of time. I try to not get mad. I try to not escalate the situation, even though my brain is often screaming, "Stop it! Shut up, you donkey!" and a few other expletives. So I'm needing to be calm. Sometimes I have to exit when I feel in danger. I can do that now because of the age of my son, but mostly I remain close by. I try to remain present, even to those screaming rages, and not commenting on them till he's kind of blown his fuse. I use soothing, song-like, simple, concrete messages to help regulate and connect. I want to run, of course. I want to reject this overwhelming distress, but I'm doing the opposite. I'm being there. Soft messages, slow movements. It will be okay. I know you're upset. You've had a tough day. Basically trying to be attuned to the situation. Sometimes I offer food, water, comfort toy, but mostly I'm waiting for the storm to pass. And once that regulation comes back, I'm trying to reconnect. I'm trying to rebuild that hurt relationship. I'm sending messages. I'm doing stuff to show, well, I still love you. I am hurt, but I'm not rejecting you. In my head, I'm wanting to push that person away, but I recognise that's just the way I feel, and it's okay to feel that way. And lastly, we get to reasoning, and only recently, in the late teens with my lads, have I been able to do what I would call reasoning. And, due to reasoning delays. So now it's often about asking, how can I help you when you're distressed and unable to self-calm? How can I help you self-calm? What works for you? What was going on for you today? And I have to reason with my lad at his ability level, which is not sophisticated. It's also vital that I self-care, of course, because I need to de-stress. I need to phone a friend, I need to go aqua jogging, talk to my partner who really gets it. So those are some of the things I try to do to get by. Okay, well, I know that was a bit glitchy for some of you. I've got a tiny little podcast from my son who contributed when I asked him a few questions. So I'd just like to play that slide too.
How can caregivers, parents, help them calm down or cope with a rage? Caregivers should be aware of the situation and be vigilant of the surroundings and why the young person is upset, such as listening carefully to the young person who is getting upset or dysregulated, and being there for them or asking them, do they want space or if they are okay? For example, if they are all up in your face, then try reassure them that everything will be okay. How can professionals help with young people who are in a rage? Well, the main thing is here, is that they have to keep in mind that the child might be triggered by a situation to do with the professional. So keep once again reassuring that everything will be okay. Also, that they might need some space. So ask them and put it in a simple manner of speech for them, because their brain will not be thinking right nor processing thoughts properly. I think it is important to remember that they will be heightened, so even just doing things such as getting a coffee to re-regulate their brain into a simple but much better mind frame will be good. In my personal experience, this has worked, and even just letting the young person vent or say their frustrations and being there to listen and once again reassure them that everything will be okay. Any advice to young people to help themselves stay calm when they are ready to explode? One of my favourite quotes and self-affirmations is, well, just know that there's always a light at the end of the tunnel, no matter the situation or circumstances. Thank you.
You can see that I have conversations with my son around these issues now, and I get him to try and think about what would make a difference. I mean, I personally would find coffee would further stimulate me, but he finds it calms him down. So you've got to find out what will work for the individual and the family. You want to obviously be talking to them about their ideas and solutions, even if their ideas seem a bit wacky. I remember the first time we suggested our son kind of have a tracking monitor to his wrist, and people were saying that's an abuse of his human rights, and he was maybe 13 or 14, but he was basically in the most ridiculously risky situations. So he was not safe, and no one was keeping him safe. We were the only ones trying to keep him safe. And this was one strategy that probably would have kept him safer had we been allowed to actually use some sort of bracelet. So we got pooed, but down the track, when he'd been accused of a few, car thefts with others and various assorted things, they were absolutely running to put a bracelet on him. And it just makes us so angry when people use, punishment to implement something rather than actually think well-being, which is the starting point, really, for families in the vast majority of cases. So we use this 8 magic keys a lot here in New Zealand to, across a range of issues going on for our children. So for some people, this might be helpful because it's, again, going back to where is the level of my child. Supervision, my child age 19 still needs an awful lot of supervision. He doesn't get it. The days he's not supervised are the days where a lot more chaos ensues, I can tell you. It's just the reality. And because people go, well, sorry, we cannot enforce that on a, 18, 19-year-old, regardless of their functioning capacity. But if he had an intellectual disability, we might. So, that's kind of interesting, really. So, yeah, we need bespoke programs so that whatever's going on in those brain domain challenges, we can advocate for services and supports. And I'd just like to see, a lot more services supplied that are focused on FASD, but also are willing to cross over into this, not just calling it challenging behaviour, but to call it out for what it is at times, violence and abuse, without destroying the family. Too many families are destroyed when it becomes a police justice issue. So I haven't got positive experiences, and I've had, we've had about 6 to 8 years involvement with justice. I've got no happy stories really from justice, and that's with all my skills and ability as a professional and an advocate in this space. Another great model is what we call the reframe, respect. Actually, it's probably called something else, but it's basically an adapted table from education that talks about when we see the behavior that we're not happy about, what is it we're thinking? What's our gut feeling? We're annoyed with the person, we're getting angry with them, they're being lazy, they want attention, they're not fitting into the rules, whatever those rules are. But what's really, really going on? And taking that brain-based approach, unpacking perhaps the neurodevelopmental issues that might be going on in a whole range of areas: memory, language, communication, sensory. that might help us step back and be less judgmental and actually go, okay, how do we accommodate? How do we accommodate? I'm not saying we say that violence can carry on, but it's like, how do we actually work with that to keep more people safe, to keep the whole family safe, obviously. And that can be tricky, but sometimes that might mean, you know, the child, young person going away for a while, but also sometimes, you know, it may be that one of the parent needs to go away for a bit longer to have a break, and somebody else, you know, comes into the house a bit more. I mean, there's got to be more creative ways of keeping families together. I mean, yeah, it's a hard one. This is a great publication, Essential Elements of FASD-informed Care, easily downloadable, so I'd encourage you to download that, have a wee flick through. It's a beautiful holistic model, talks about all the different areas that might need, you know, client-centered practices, how to overcome stigma, building those relationships, and of course you can apply that in this particular area. You know, you've got plenty of programs going on in Australia. I mean, essentially, the last couple of slides are, you know, talking about these resources, and also mentioning, of course, that you've got plenty of your own resources to draw on, and people can have the slides. But obviously, I've, you know, virtually come to the end of the presentation, and concluding that we all need to live our best lives, and that means that we've got to support the whole family. We can't just target one or two members of the family, and we can't necessarily intervene in the same ways that we would for, you know, adult family harm situations and interpersonal violence. We need specialist programs for our families where neurodivergent conditions in particular are, you know, fairly high. So there we go. Sorry about the glitches. That's the resource slide. You can look at that later. My final slide is, yeah, just saying that, you know, we need to care for the whole family. We need to have that, yes, disability, human rights focus. You know, we need to be shoring up the dignity of others, but we have to have that nothing about us without us. So I'm trying to, with other peers, develop resources as I go along, but also to include my son in that process, because I want to ensure that, you know, we find a pathway forward that is destigmatizing, that understands the disability, that actually is about ensuring the resources for those young people to live good lives. They deserve to live good lives. But, you know, they will live their best lives with the support of loving, caring people around them. So they should be able to have the same life that others, you know, without this disability have. But at the moment, certainly in Aotearoa, New Zealand, that is not the case. And therefore, families are also affected in that respect by being isolated and alone. So I'll leave it there because she thinks the glitch gremlins are about to hit again.
Thank you very much for persevering with some of those tech glitches. We appreciate that our video today has come from across the ditch in New Zealand, and thank you so much for your time today, Anita, particularly in sharing, I think, your own lived experience and, you know, and literally giving your voice to this discussion in the form of recording, and that of your son as well. It was really quite insightful to see just some of the, you know, on a daily basis, those challenges for parents, carers, but also for the dynamics of the family. There's some huge implications for the families that we work with, particularly more vulnerable groups, as you said, such as those living in out-of-home care situations. I think that, as you mentioned right at the start, we need to dispel a few long-held myths around FASD, in terms of perhaps there being even a professional lag in disbelief that a young person might be living with FASD if the sentinel facial features are not there, whereas you've highlighted that that's only possibly occurring in 10 to 15% of cases. And also, I think just really interesting for us to view that there's really big overlap and therefore misidentification with some other known conditions, ADHD and autism. So I think, yes, really good, useful information for this cohort of practitioners that have joined us today. Now, for those, I understand a lot of people will need to hurry off to their next appointment. There were a couple of questions that people added in their registration, so we'll try to put together a bit of a resource pack and we can send that out to people. And also for practitioners looking for further resources, information sheets, additional webinars, there's heaps of information. If you go to the No FASD website, which is Australia's national organisation for FASD, you can find a lot of things there. Additionally, we will be sending out a recording of this webinar today. So for those who couldn't catch the whole thing, that will be available. Please do, if you are able, please please complete the survey, the evaluation survey that Emma has just popped in the chat. There was a bit of a computer glitch for me there. We really do appreciate your feedback and your thoughts in terms of the content that we deliver to you. And thank you again for attending. Thank you again to Professor Anita Gibbs for all of her time and effort in sharing this discussion today. Thank you all.